Good evening. Thank you for joining us tonight. I'm Darrell Yamashiro, the Chief of Pediatric Hematology, Oncology, and Stem Cell Transplantation at the Columbia University Irving Medical Center, Herbert Irving Comprehensive Cancer Center, and the New York Presbyterian Morgan Stanley Children's Hospital. Tonight, we invite you to the webinar on cutting-edge therapies for children with cancer and blood disorders. I'm very excited to discuss Columbia's initiatives in gene therapy for hemoglobinopathies, novel drug delivery systems for brain tumors, and our precision and pediatric sequencing program, PIPseq, and how we're using innovative systems, biologies, and methods to identify unique therapies. I'm told we have been joined by over 110 participants. Now, first, some housekeeping notes before I introduce our expert panel. Our intention is for this to be an interactive discussion, and we have allotted time for questions and answers. Please type in your questions as they occur to you, and we will attempt to answer as many of them as possible. Following the broadcast, a summary document containing key points will be sent to all participants. So don't worry if you can't get to your question tonight. We'll attempt to answer them in the document. Now it is my pleasure to introduce the panel of distinguished speakers from Columbia University. Dr. Monica Bhatia, Associate Professor of Pediatrics and Section Chief for Stem Cell Transplantation. Dr. Stergios Zacharoulis, Herbert and Florence Irving Associate Professor of Pediatric Neuro-oncology. And Dr. Jovana Pavisic, Assistant Professor of Pediatrics. Finally, it is my distinct pleasure to introduce you to Dr. Max Gomez, the multi-Emmy Award-winning broadcast journalist and correspondent for CBS. Max will be interviewing our panelists. So Max, why don't we get started?
Very good. Thank you, Darrell. I appreciate the introduction. I have asked all of our panelists and been given permission so that I don't seem disrespectful to address them by their first names. They are all very distinguished and have long titles. We'll just go with this to make it a little more interactive and a little less formal. I'll ask each of you to give us a little brief introduction of yourselves, what your research interests are, and so forth. And so why don't we begin with Monica. Tell us a little bit about yourself, and then we'll go from there.
Thank you, Max, and thank you, Darrell, for that very kind introduction. My name is Monica Bhatia. I am the director of the Pediatric Stem Cell Transplant Program here at Columbia University. We transplant approximately 50 patients a year with both malignant and non-malignant conditions. We are also providing novel therapies such as CAR-T and gene therapy to our patients as well. Over the last decade, we have grown to be one of the largest hemoglobinopathy centers in the country, performing both related and unrelated donor transplants. My clinical research interests in particular are providing curative therapies to these patients with sickle cell disease, whether it be through bone marrow transplant or gene therapy procedures.
So tell us a little bit about who are the patients then who are appropriate then for these transplantation, just to get us started.
So my focus is on sickle cell disease, and sickle cell disease, as many of the audience will know, is an autosomal recessive condition which afflicts about 100,000 people a year in the US. The clinical severity is variable, and it's really unclear who will be most severely affected and who will not be. There are limitations in what we can do for a lot of these patients. But over the last 40 years, we have seen the life expectancy change from 10 years of age to about 50 years of age. And while that is a large improvement, that is still significantly lower than unaffected people with the disease. So at this moment, matched sibling donor transplants are one of the curative options we can offer these families, with cure rates of about 95%. However, only about 15% of patients actually have a matched sibling donor. And so it's for these 85% of patients that we really need to do more investigations. And so that's where I focused a lot of my interest, is performing unrelated donor transplants and now extending that to gene-based therapy trials to help cure these patients of this disease.
Okay, good. We're going to dig more into that in a little bit. And I should say that we have three very kind of disparate topics and experts here. For New Yorkers, we call that a gamish of things to talk about. So it'll seem like we're not overlapping very much, but I think we will. So Stergios, why don't you tell us a little bit about yourself and your research interests?
Yeah, so I'm Stergios Zacharoulis. I'm a pediatric neuro-oncologist. I have been here for the past couple of years. So I'm taking care of children with brain and spinal cord tumors. Here at Columbia, we have developed a very comprehensive neuro-oncology program with multidisciplinary team involvement, not only in the clinical level where all the relevant specialties are involved, such as radiation oncology, neurosurgery, neurology, neuropathology, etc. But more importantly, at the clinical research level, where we have engaged multiple specialties from even areas that are not even related directly, traditionally to medicine, such as biomedical engineering, molecular biology, etc. The reason we have engaged this type of specialties because we are developing a program that focuses specifically on drug delivery, trying to identify novel methods of delivering drugs for patients with brain tumors to overcome the blood-brain barrier issue. And also one main pillar that my colleague Dr. Pavisic is also very much involved in this is to modify and tailor the therapy specifically for the actual tumor that each patient has, i.e. precision therapy for brain tumors.
Very good. Thank you. When we think pediatric cancer, I think most people tend to think of leukemias. How common are brain tumors in children?
Yes, so brain tumors, for example, every year we have approximately 4,500 new diagnoses. So we have 4,500 children newly diagnosed with brain tumors in the United States. So practically speaking, worldwide, this is approximately 5 new patients per 100,000 population. The interesting thing is that our incidence, as in brain tumors, is almost equalizing leukemia now. Although there is overall a slight increase in the brain tumor incidence, unfortunately, we have not made significant progress in terms of curing more patients for the past decade or so.
Good. We're going to dig into that as well. But let's move over to Jovana and tell us, as a pediatric oncologist, tell us a little bit about yourself and what you do.
Thank you, Max, and good evening. Thanks for having me here tonight. So my name is Jovana. I'm a pediatric oncologist, and I primarily work on research, as you heard, in the area of precision cancer medicine, focusing on the role of cancer genomics and molecularly targeted therapies and their direct impact on the clinical care of pediatric oncology patients. And so I have a background in mathematics, and I've always been fascinated by how mathematics can help us understand complex biological systems and generate insights that might not be apparent when we study these systems broken down into their individual pieces. And of course, cancer is an extraordinarily complex living system, and we've had an explosion of data in the last decade, particularly from recent advances in the molecular profiling of tumors, making it very well suited to this type of systems-based analysis. And so my goal is to really further the field of pediatric precision oncology by leveraging the latest computational methods, software tools for analyzing cancer genomic data to provide mechanistic insight into cancer biology and to predict how individual cancers will behave, what therapies they might respond to, so that we can find new approaches. And Columbia is really a leader and at the forefront in this field, and we've had this precision in pediatric sequencing program that's been implemented in 2014 to offer comprehensive tumor profiling to high-risk pediatric oncology patients. So I'm working to bring these new technologies into that program so we can improve what we find.
So Jovana, does that, in terms of pediatric oncology, include liquid tumors, solid tumors, brain tumors? It's the entire field that you're applying precision oncology to?
Yes, and so, you know, we basically precision oncology refers to just tailoring cancer care to individual unique characteristics of the patient. And we have been doing this in pediatric oncology for a long time in terms of looking at tailoring therapies to the specific diagnosis, histologic subtype, the patient's clinical characteristics across all the tumor types. And so now really what we're talking about in this era sort of molecular oncology is how can we use the cancer genetic data to really move this forward. And we can, cancer is really a disease of the genes and all cancer types. And so really it can be applied across all tumor types.
Interesting. So just to be clear, because this is something that I end up having to explain to people all the time, when you're tailoring something, as you said, used to be to the patient, you're actually tailoring it to the characteristics of that patient's tumor, because not all cancers that have the same name are the same.
That's exactly it. And that's, I think what is particularly interesting about some of the new technologies that we're applying is what we've found from sequencing patient tumors is that many tumors behave in the same way phenotypically. You know, we see patients, for example, with a certain bone tumor, osteosarcoma, they all behave fairly similarly clinically and in their response to treatment. But when you look at their genetics, you see that no two patients look alike in terms of their mutational profiles. But what we can do actually now is leverage some of these systems biology methodologies to try and understand how do all these disparate genomic changes, where are they converging, and what is really the kind of key driver mechanisms that we can then target and that are making the osteosarcoma kind of state look so similar across all patients.
Interesting. So Monica, let's move back to sickle cell disease for a moment. I've done some work with different groups on that. Aside from, as you said, there's an increase in life expectancy, but nowhere near what we would like or what it should be. Other than stem cell transplantation, where else can we go to try to make outcomes better?
No, that's a great question. And so historically, it's been more medical treatment, just more focusing on the complications, not so much curing the disease. And so things like chronic transfusions, penicillin prophylaxis, better immunization strategies, and the use of hydroxyurea have really helped prevent the symptoms, but not so much cure the symptoms. And that's why stem cell transplant is so attractive. However, as I mentioned, it's not really applicable to a lot of people. And I think there's always been a little bit of a pause as to when to refer a patient for transplant, even if they have a matched sibling. Do you wait until they get sicker? Do you wait until they get older? Do you do it younger? Unfortunately, with stem cell transplant, patients are exposed to high doses of chemotherapy, and that is always a drawback and a consideration we have to take into account. But you know, it's been my experience that initially the initial studies that we have done looked at the most severe patients, patients with strokes, patients with acute chest and multiple pain crises. And despite having high doses of chemotherapy, those patients actually had survival rates of about 85%, which is very exciting. But through better supportive care now, these patients are surviving into, you know, well into 95 to 100% survival. And so we're actually offering transplant to anybody with sickle cell disease, with SS disease, who has a sibling donor, regardless of complications. But again, there's not that many. And so these gene-based therapies are kind of the new thing on the horizon, which are very exciting and really could change the landscape of the way we treat patients with sickle cell. They are currently
complicated, so I want to come back to that. But one
okay.
question: at what age then do you go ahead and you said since the outcomes are so much better, are you moving the transplant age younger and younger?
Yeah, usually I transplant, and most clinical trials won't transplant anybody unless they're 3 years or older. The high doses of chemotherapy, we do want to not cause learning disabilities because it's usually a chemotherapy-based regimen, not TBI, but there still are learning disabilities that we can cause. So we typically recommend transplant around age 3 and transplant up until now. Patients are being transplanted well into adulthood, which is really great because people 10, 15 years ago who wouldn't have been considered for a transplant are now being afforded that opportunity. So I know my adult colleagues are transplanting well into their 50s now, which is great for those patients.
That's exciting. That's exciting. Stergios, talk to me about, you mentioned earlier the blood-brain barrier, which I recall from my days in neurobiology, is kind of a double-edged sword. We want it, but tell me what it is and how that kind of impedes treating brain tumors in children, or in adults for that matter, but we're talking children.
That's exactly right, Max. It is a double-edged sword because although it protects us from toxins or unwanted environmental exposure to things that we don't want to have in our brain, obviously, unfortunately for treatment, when it comes to treatment for brain tumors, it is one of the main obstacles, that, especially for tumors that maintain the blood-brain barrier, in a way that it doesn't allow the drugs to penetrate in adequate concentration. So, I mean, as a reminder for our audience, the blood-brain barrier, although sounds very simplistic, in fact is a highly complex unit, which comprises of astrocytes, endothelial cells, stroma, connective tissue that are all in a constant dialogue between themselves with a lot of adhesion molecules. And as a reminder, we have multiple ways to enter the CNS. So the blood-brain barrier allows, for example, only lipophilic molecules, less than 400,000 of molecular weight through diffusion. But there are also these very important mechanisms, such as receptor-mediated movements or protein-mediated for other molecules like glucose, etc. So this, as you can imagine, given the variety of the size, of the molecular size and the chemistry of each drug, it is a big problem. Obviously, it's not the only problem for brain tumors, because there are brain tumors that are particularly chemosensitive even with intravenous medication. But as we advance the knowledge in biology and imaging, we realize that there are definitely a significant proportion of brain tumors where the blood-brain barrier remains intact. And therefore, it is our duty as neuro-oncologists to overcome that. And historically, we have tried with different approaches with medications primarily, and unfortunately, all of them have failed, mainly because either these attempts involved highly toxic medications or simply because of failure. So our main pillars of our research is to overcome this obstacle of the blood-brain barrier with novel technology. And the two main ones that we're working on, and we are in a very unique situation here at Columbia because we have the technology to do that, is one is the convention enhanced delivery, and the second is the utilization of focused ultrasound to open the blood-brain barrier.
Good. I want to get back to describing that a little bit in more detail and how you utilize that. But let me go back to Jovana to ask you a little bit about precision oncology. And part of that at Columbia is something PIPseq. I keep wanting to call it pipsqueak, but I guess that's not.
Almost.
Right. What is that, and how does that fit into precision oncology?
Right. So the PIPseq program, or the Precision in Pediatric Sequencing program, really stemmed from, over the last decade, we have learned a lot about how the molecular makeup of patient tumors affects things like prognosis, their response to therapy, how it can help us make more precise diagnoses. And this has, for the most part, been learned from sort of large discovery research type studies. And now we know for many different cancer types, for example, across many leukemias and medulloblastoma, for example, in terms of brain tumors, we have defined very specific molecular subgroups of patients that have very distinct outcomes that respond to different therapies. And now what we want to do is bring all of this knowledge into direct clinical practice. And so that's where the PIPseq program came about, was really to bring this into routine clinical care for patients to make sure it has a fast turnaround time. And so the program was established at Columbia in 2014, and it involved a very large endeavor from figuring out how do we talk to patients about this and consent patients to genomic testing, to what are the devices, facilities, labs, bioinformatics tools we need to analyze and interpret this data appropriately, and then how do we share that data back with the patient and with the treating physician. And out of that, we ended up doing these weekly molecular tumor boards. And so right now, the program has really expanded over the last 5 years. And we provide comprehensive sequencing both at the DNA and the RNA level, so whole exome sequencing and transcriptome sequencing to pediatric oncology patients that have what we kind of call high-risk disease. So they're at risk for having treatment failure from standard of care therapies, or who have interesting, clinical phenotypes, rare tumors, potential family histories that should suggest a cancer predisposition syndrome. And for these patients, we can do sequencing of their tumor, have a turnaround time of 3-4 weeks, and then discuss the results and potentially make therapeutic decisions or changes in their treatment plan based on these results. And that's the overall goal, is to really implement this genomic-driven medicine into pediatric oncology clinical practice and see how that impacts the decisions, the treatment decisions that we're making.
That's really remarkable because I recall when the human genome was first sequenced, and that was a $3 billion effort, and now you can do it for the price of a expense account dinner in New York City somewhere.
Exactly.
But are you then sequencing virtually every tumor that walks in the door?
Not every tumor. So we basically sequence the patients that are high risk. And now I'm not 100% sure, maybe Darrell knows exactly the percentage of patients that come through our practice that end up getting sequencing, but it's mostly, we reserve it for patients who present with generally high risk disease where we expect their 5-year overall survival to be less than 50%. And so where we need potentially to find alternate therapies if they don't respond to their standard of care therapy. So we have some ideas of down the line how else we can treat these patients. We also, a big component is looking at the kind of ultra rare pediatric tumor types. So in general, pediatric cancer is a very rare disease. And so getting sufficient data on the patient population, especially to make sort of genomic analyses and associations between genotype data and phenotype data, is very difficult. And so particularly for the ultra rare tumor types, we want to do this to be able to potentially suggest new therapies that we may not be able to get to just from sort of empirical testing across many patients.
And presumably treatment failures as well?
Yes, and relapsed refractory patients, we certainly sequence to see what new directions we can find.
So speaking of genetics, Monica, that is very much the issue with sickle cell disease, but we kind of know the genetic issues with sickle cell disease, right? So how do we factor in genetics or gene therapy into sickle cell disease?
So the nice thing about gene therapy, and I'll explain the different ways that we can approach these gene therapy or gene-based approaches, because there are different ways that we can approach it. There are a lot of complications using bone marrow transplants, such as graft versus host disease, graft rejection, and other complications, because you are getting cells from somebody who is not yourself. And so that's kind of a very attractive option in using gene therapy, because you're actually using your own cells. And basically there's two ways that these gene-based approaches are being used. And one is what we call gene therapy, and I think that's really what people are seeing more in the headlines, versus a gene editing approach. And so the purpose of a gene therapy approach is to replace a cell with a functioning gene to make up for that gene defect. And so the way we do that is through a vehicle called a vector. And the vector contains a functional gene that is then incorporated into the patient's cell. And so in the case of sickle cell, we use what we call a lentiviral vector that encodes for a hemoglobin that is a functional beta globin unit. And so when inserted into a patient's cells, the hope is that these cells will grow to contain not the sickle cells, but this functional hemoglobin. And so patients are brought to our unit. Their stem cells are collected, and then these cells are then sent to a centralized facility where the cells are then what we call transduced with these genetically engineered, with the lentiviral vector that contains the functioning globin gene.
So before you get too far down that road, I want to make sure that everyone understands that. So you're using this lentivirus, the vehicle.
Yes.
It has had the correct hemoglobin gene
Yes.
inserted into it. The virus then delivers that into the patient's stem cells, blood-forming cells.
Yep.
And the goal and the hope and the outcome is now these cells start to make the functional hemoglobin.
Exactly.
Then what?
Then, so the hope is that these cells are transduced with enough of the functional hemoglobin. Then patients are admitted. They essentially undergo what we call an autologous stem cell transplant, where they receive high doses of chemotherapy to wipe out their old bone marrow. And then these cells are infused, where they ultimately home to the bone marrow. And the hope is that they grow within the bone marrow. And usually patients then start accepting the graft. So it is like you're getting a graft, but it's your own cells that are now genetically engineered. And the studies have been very, very encouraging. The initial studies did not have as good results as we had initially thought, but there was some changes in the manufacturing. And the initial study that was just reported in 25 patients all have accepted the donor cells. After 6 months, all have a hemoglobin level of 11 or above, transfusion independent, and no signs or symptoms of sickle cell disease. So obviously, this is very early. I believe the longest follow-up was about 4 years, so we still don't know really what the long-term goal is, but it has seemed that after 6 months, there's really been a sustained level of this new beta globin in the blood, and we can monitor that through a simple blood test.
And in fewer crises, I presume?
No crises. No crises.
I want to come back to gene editing in a minute, but one more question about this particular approach. Because it is engineered autologous cells, presumably you don't have the issues of the same graft versus host or rejection.
No, there haven't. All patients are required to store a backup amount of cells in case they don't quote unquote engraft, and so we can infuse those cells so they don't remain pancytopenic. But for the most part, that has not been needed, and patients have done very, very well. And most patients are probably in the hospital for about 30 days, which is pretty on average for an autologous stem cell transplant. And honestly, most of the side effects that patients have seen have been more because of the chemotherapy and not because of the actual product.
Interesting. Okay, we'll come back to gene editing because that's another hot area as well. But Stergios, let's talk brains here. You mentioned before the number of cases. Did you say something about prognosis, and can you predict prognosis based on genetic sequencing of a patient's tumor? Do you normally have that in a child, to have a biopsy or have surgery to be able to sequence a tumor?
Yes, so this field has evolved dramatically over the past decade. Just to give you an example, the WHO classification for brain tumors has expanded the number of diagnoses to something around 70. The reason being is that molecular biology has been integrated in terms of classification and prognostication of these tumors. But overall, let's say from the general pediatric point of view, the general comment is that if a child is diagnosed with a brain tumor, there is approximately 75% chance of cure. Of course, this is a misleading figure. It's a number that is a statistic that practically reminds us why statistics can mean nothing at the same time as can be useful. Because obviously, as you can imagine, there is a wide range of, in terms of the prognosis. There are tumors like, thankfully, the most common ones, the low-grade gliomas, where the cure rate is anywhere between 90 to 100%, some of them with surgery only, or even with novel therapies that we have, with targeted therapies that are substituting even chemotherapy. Currently, we're examining this question. So the sequencing of the tumors has already been useful even in low-grade tumors. When we go to high-grade tumors, we have the medium risk, let's say, overall diseases, such as medulloblastomas, where the molecular classification is imperative in terms of decision of the treatment and risk stratification. For these patients, we have a prognosis of approximately anywhere between 50 to 75%. Unfortunately, though, still with cytotoxic chemotherapy, even high dose of chemotherapy, and the use of craniospinal radiation, which has obviously detrimental effects long-term for some, but not all of these children. And finally, we have the third group, which is the unfortunate group with patients who practically have very poor prognosis. And the extreme of it is one of our interests in our group, which is the diffuse intrinsic pontine glioma, or the most recent modern term, diffuse midline gliomas, where unfortunately the prognosis is practically is considered a fatal disease with only case reports of survivors. And this is where mainly our efforts are concentrated to have an impact.
Interesting. All right, we're going to come back to, I still want to come back to the blood, opening the blood-brain barrier, because that really fascinates me. But let me go back to Jovana. And by the way, I encourage all of our panelists, if you have a question of each other, jump in. Don't just leave it to me to grill. But Jovana, tell me, it occurs to me that, say, in the PIPseq, did I get that right?
Yeah.
I still pipsqueak, but in the PIPseq program or approach, you still are you do the molecular or genetic sequencing, but it strikes me that you still have to correlate that with clinical outcomes. So in other words, the genetics don't necessarily mean that much unless you've had some prior experience that this particular genetic sequence should be directed towards A, B, or C therapy. So does that mean we really need to expand this kind of correlation, correlating the phenotype, clinical outcome, and so forth with the genetics?
Yeah, so that has been, I think, one of the difficult parts of cancer genomics. You know, when this first started, we were very hopeful that, you know, with sequencing, we'll identify those mutated genes that are driving the cancer, we'll be able to target them, shut down the cancer, and wonderful, we've solved it. But unfortunately, things that we've learned over time are much, much more complex than that. And so what we've seen is, you know, the same gene mutation can cause many different cancer states. And there's just a lot of many varying factors that affect how it actually expresses in the cell, how it actually changes the program of the cell. We have also seen that different patients have different combinations of mutations, and we all have about 20,000 genes in our body, and so the number of potential mutational patterns is huge. And so it's even more than the number of atoms in the whole universe. And so I'm really trying to study cancer, you know, on a mutation by mutation basis is really hitting the tip of the iceberg. And then the second piece we've seen is whether, even if you have a particular mutational change, say something like an EGFR mutation that can be targeted with a drug like erlotinib, it seems very precise and you should be able to treat it. We see that really only 30% of patients respond to the targeted drug. And so there are resistance mechanisms and other pathways. And so that's one piece. So really this is where we're trying to use some of these systems biology tools to kind of understand a bit better how these complex molecular interactions are working and to address some of these problems. And also one of the big areas, especially in pediatric oncology, as I alluded to earlier, that some more rare diseases, gathering enough data to make what you're saying, some of these associations between genomic findings, clinical outcomes. One of our big limitations really is not having enough data to make statistically significant and meaningful findings. And so a lot of our approach actually kind of focuses a bit on an N of 1, individual patients, seeing their changes seeing if we can target them, looking at potentially preclinical models, things like mouse models, seeing if we can replicate what we're finding computationally in those mouse models, and then treating the patient, and almost looking at it as that N of 1 approach rather than just because we don't have enough data across all the cancer types. And so those are many different areas that we're working on to address that problem.
So it also then strikes me that it would be good for the field, but also potentially for the clinical outcome of an individual to have more patients referred for this from community oncologists and community pediatricians.
Yes, exactly. And this is one of the wonderful things that we've implemented back in 2016. The Sohn Foundation gave us support to be able to expand this testing to surrounding hospitals in the tri-state region. So now we can offer this testing to patients treated at all institutions in the New York, New Jersey, Connecticut tri-state region. And this has doubled the amount of patients that we've seen, that we've sequenced, and really helped us build a greater experience. And one of the big national initiatives now that we're hoping to be a part of is really this Childhood Cancer Data Initiative that was launched last year to really try and collect and aggregate pediatric cancer data and standardize it across institutions nationally and in the world, and to make sure that this data is publicly available and shared, and that we're all learning from it. And so this is something that Columbia is also a part of, and we're hoping to standardize some of our sequencing data and our clinical annotation so that we can share it in public repositories through the National Cancer Institute, and hopefully help with this part of it.
Great, good. So Monica, Jovana keeps teeing up genetics for us here.
I know it's a great lead-in.
but before we get in, I want to ask you about gene editing and CRISPR. But let me take sort of a half a step back for a second, because I think most people and most parents would think that a child with cancer is about as bad as anything that could happen to them. But sickle cell disease is also a very terrible thing. Some of the groups that I've worked with said that the children or teenagers or whatever who show up with a crisis in the ER, for example, are labeled as drug seekers because people and pediatricians and ER docs don't quite understand the pain of a sickle cell crisis. Tell me a little bit about that, and then let's talk about CRISPR.
So I think you're right. You know, I think these children, it's very unclear when a child is born with sickle cell disease how severely affected they will be. I think we do know that there are patients who before the age of 1, if they have dactylitis, which is swelling of the hands and feet, low hemoglobin levels, those tend to be the patients who have poorer prognoses. But I agree, it's a lifetime of pain, of complications such as stroke, organ damage, splenic sequestration, infections. You know, honestly, there's many adults who go into adulthood not being able to maintain a steady job. About 50% of patients with sickle cell disease are right now on disability because they're unable to find permanent employment. A lot of employers don't understand the reasons why they need to be out of work. And so I think if you speak with adult hematologists versus pediatric hematologists, they are much more apt to refer their patients to curative therapies, because I think they see where these patients' lives are headed. And, you know, fortunately, as a pediatrician, I've really seen my patients' lives change completely in terms of just you know, being able to be in school regularly, keep up with their peers in gym. And so I think I really do feel like if we can treat these patients earlier, they don't ever need to know a life of pain or crises or strokes or very debilitating complications.
So part of the solution is sort of non-medical, it's educational.
Agreed. And I think, you know, a lifetime of sickle cell sometimes, and I don't mean to sound crass, but sometimes I feel like children with leukemia, while they do have to undergo 2 to 3 years of treatment, hopefully that's all for the majority of those patients. Whereas for patients with sickle cell disease, this is a lifetime, and it's very difficult. You know, there have been studies to show, you know, even healthcare costs, how much this is for the healthcare system, and lifetime cost for taking care of a patient with sickle cell disease has, you know, is usually about $1 million per patient. So, you know, that's why transplant, while it is a a large investment up front, long term, you don't see any of the healthcare utilization.
Exactly, exactly. Okay, I promise we're going to come back to gene editing, but let me come back to the blood-brain barrier with Stergios. It's there to protect us, but we want to get medications, therapies into the brain, into the tumor, really. Are there ways to get around or open this blood-brain barrier? And tell me about those.
Yes, there are various ways. I will mention there are at least 6 ways, but with a conventional enhanced delivery, with focused ultrasound, with intra-arterial therapies, and some others. But I will focus with the work that we do here, so I can explain a bit of our research and where we stand with that. So the 2 pillars of overcoming this obstacle for us, one is the conventional enhanced delivery, and the second is the focused ultrasound. Conventional enhanced delivery is defined as the administration of drugs into the brain parenchyma through catheters, but utilizing constant pressure so that the drug is administered to the brain parenchyma not through simple diffusion, but based on bulk flow gradients. This way, in simple terms, what it means is instead of having a drug delivered within few millimeters within the brain parenchyma, ends up being delivered within few centimeters instead. Obviously, we cannot cover the whole brain, but at least, for example, we can cover the pons, which is the area in pons and gliomas, the fatal brain tumor, that we have shown that with this method that we can cover with medication. So we have a huge team here at Columbia with both run by Jeff Bruce and Peter Canol, the neurosurgery and the neuropathology, and we're doing both preclinical and clinical work on that. So it starts with animal models where we use catheters with various drug combinations, all the way to the clinical end of the spectrum of the clinical trial that we actually already opened a few months ago, which is very exciting, of where we use a novel device. So, for example, to avoid confusion, we're not talking about simple injection of a medicine directly into the tumor. This has been tried for decades, and also this is not successful or good enough. What we are talking about is having novel technology to allow microinfusion over longer time within the brain parenchyma with repetitive chronic infusions. In simple terms, what we do is we take a port which has a pump that has a software in it with a drug, which I will discuss a little bit later on, that is already pre-filled, and this pump is placed under the skin by the neurosurgeons and has a catheter in the end that is being fed all the way from the skin directly into the pons, into the brain parenchyma. Now, what is the fascinating thing about this is that, first of all, the drug, the infusion of the drug is regulated wirelessly with a software which looks like an iPad, almost like the baclofen pumps. So the patient is not connected with anything, and there is as a small infusion as 0.2 liters per hour directly into the pons over a very long time. So the patient sits there, plays with their games, etc., and there is the pump there that infuses directly the drug into the brain. The vision for this, although we are still, of course, examining the safety of it, and we have some preliminary data that are quite promising, is the vision is that we will be using this device and this methodology for chronic administration and treatment for this fatal disease, eventually even outpacing. Of course, we have long ways to achieve that, but it is practically a very different way of approaching brain tumors. That's the conventional enhanced delivery. What is the limitation of that? The limitation is that it is an invasive process. The patient requires surgery or requires a catheter. And of course, there are tons of things that we need to figure out in terms of which drugs are the best, how we can improve the diffusion, how can we do it safely in terms of expanding to other parts of the brain. Obviously, this is why we do so much research.
Great. And I promise I still want to come back to focused ultrasound, but let me go over to Jovana here. You mentioned earlier systems biology, which I'm not sure everyone understands exactly what that means, but a part of it, I believe, is something called Arachne and or Vipre. Tell me a little bit about that briefly and in as simple terms as possible. Oh, I think you're muted still.
Sorry about that. Just had a crying baby for a minute. So I mentioned before that really if we're trying to look at cancer as individual mutations, the amount of possibilities are endless and it becomes very difficult. And so really what we're trying to do with something called systems biology is look at cancer kind of as this complex set of levers and pulleys and gears that make something happen. And so instead of using brute force to study each component, we really want to try and build a model of how are all these things working together. So how are regulatory proteins in the cell, things called transcription factors, regulating all the other genes in the cell. And once we have this model kind of developed and built, then we can start to answer very complex questions much more simply. And so our goal with sort of systems biology and these methods is to turn kind of precision oncology from an empirical science to a very quantitative predictive science. And so what we're using, these methods that you talk about, were developed in Dr. Andrea Califano's lab here at Columbia, and he's a world-renowned leader in systems biology. And what he has done over the last 10, 20 years is really study how every gene is being regulated by these proteins called transcription factors. And he's been able to build this regulatory map in every tumor type almost of how transcription factors regulate the genes in that tumor. And that's very complex. If you can imagine, we have about 3,000 regulatory proteins regulating 20,000 genes. So it can get quite complex. And so he uses this branch of mathematics called information theory and this Arachne algorithm to build, and it's sort of named after sort of a spider's web type thing of all these interactions. And what's very interesting then is what you can do with this map. And so now what you can do with this map is really look at individual tumors to try and find out what are the key driver proteins that we need to shut down in that tumor. And how we do that is through this Vipre algorithm. So what this Vipre algorithm does is it uses the genes that are regulated by a particular protein, and we know this from that big map that we built, and it uses those genes as a proxy for whether that protein is really active or inactive in that cell. So we know by the expression of those genes, what is that protein doing in the cell? And so we don't have to actually sequence that protein. We don't have to measure its activity, which is very hard to actually look at the activity of proteins in the cell. We can just tell by its targets whether it's active or inactive. And so we can really transform this gene expression signature of 20,000 genes into a very precise measurement of the activity of about 6,000 regulatory proteins. And from that, we can find what are the top 20, 30, 40 proteins, a very small number of proteins that are really driving the disease state in that cell. And then we can focus on targeting those small number of proteins in the cell.
Wow, you got your hands full, it sounds like. So again, we're teed up for Monica, and I said we're gonna come back. We talked before about gene replacement, right? Where we're going to replace the defective gene in the patient with sickle cell. Now let's talk about gene repair and CRISPR, which has been very hot out there. Is that applicable to this, and where are we with that?
Very much so, and we're in clinical trials right now, and they are using this to treat patients with both sickle cell disease and thalassemia, and the results are really very, very encouraging and exciting. And basically the premise between a CRISPR-Cas9 method is to see if we can actually change the DNA, and will that in fact alter the disease. And
in
so
the patient's own cells.
I'm sorry?
In the patient's own cells.
In the patient's own cells, yes. And so the CRISPR-Cas9 method consists of two, it consists of both an mRNA guide protein as well as the Cas9 protein. And so the RNA actually sticks to the DNA in need of repair. And then basically the Cas9 protein acts as like a pair of scissors that kind of cuts out the affected area, and the cell heals on its own. And so the hope is by changing the cell, it kind of has new instructions now. And so in the case of sickle cell, the gene that is changed is something called the BCL11A gene. And that usually shuts off the production of fetal hemoglobin. But now with this CRISPR-Cas9 method, it actually, it shuts down the BCL11A. And so the hope is that the fetal hemoglobin that was shut down will now restart and increase the production of fetal hemoglobin in these patients. And so as people know, back to their physiology, everybody is born with fetal hemoglobin, and in patients with sickle cell disease, that fetal hemoglobin ultimately changes to sickle. But prior to that, they have no complications because of the increase in fetal hemoglobin. And so the hope is that if we can continue to produce fetal hemoglobin in these patients after this modification, they will be cured of their disease. And there have been some studies done looking at patients with both beta thalassemia and sickle cell. And again, the patient's cells are collected. They are then treated with this CRISPR-Cas9 method, and then the cells are reinfused back into the patient after high doses of chemotherapy. And again, the complications have been minimal and really been related mostly only to the chemo itself. And patients are transfusion independent. Very exciting, by about a month after the transplant, with no sequelae of their disease. So in both diseases, sickle cell as well as thalassemia, we've seen some really exciting developments. And now the initial studies were done in patients 18 and over, and now they've decreased it now to 12. So we're very optimistic that we'll be able to offer this to more patients.
And just to be clear, because the CRISPR-Cas9 system, sometimes you take out a bad gene and try to replace it with a good one.
Right.
In this case, you're taking out a bad gene that's getting in the way of making this fetal hemoglobin,
Exactly.
which is going to substitute for normal adult non-sick
Exactly.
hemoglobin. You've told us about three different things. How do you choose between these now, between a transplant, gene editing, and gene replacement?
So I think the way I've kind of strategized is that if you have a matched sibling donor, I still think transplant is the best route at this moment. In fact, none of these gene editing or gene therapy trials will actually accept you if you do have a matched sibling donor. So still the standard of care is a matched sibling donor transplant. But I think for patients who have very significant complications, and we're really looking at patients who are at risk for stroke, multiple pain crises, or acute chest. Those patients, if they don't have an acceptable unrelated donor, I think would be ideal candidates for gene therapy. And you know, unrelated donor transplants for sickle cell disease haven't really been a home run. Outcomes are about 70%, which is much less than what we have with sibling donors. So I think if I had my option, I would probably go with a gene-based therapy before an unrelated donor.
Got it, got it. All right, Stergios, finally, ultrasound. Is this what you would call HIFU, high intensity focus ultrasound? And how do you work that to open up the blood-brain barrier without causing a lot of collateral damage?
This is a fascinating story and an incredible success of the biomedical engineering department here at Columbia and some other centers as well, but I say specifically here at Columbia because at our department of biomedical engineering, Dr. Kanofagu and Dr. Wu from radiation oncology, they have created a unique technology where the high frequency ultrasound, all these frequencies are used in order to separate the endothelial cells with the use of microbubbles. But what is unique about it, although this technology has been on for the past 10 years or so, is that this technology does not require any surgery. This happens through the skull. Through the skull, as a simple ultrasound. The device looks like almost like someone is sitting on a dental chair. but the probe is being delivered on the head of the skull, and they have done tremendous amount of work in various animal models, primates, etc., to show that despite the thickness of the skull, which mimics the human skull, using these frequencies, the endothelial cells can separate. And the most fascinating thing is that when we apply this technology, at least at the laboratory level, we have seen that you can increase significantly the concentrations within the tumor of chemotherapies, immunotherapy, and now we are in the process of, we have opened the dialogue with the FDA to get approval for our first in human, especially for children with brain tumor study. And as I said, the unique thing about it is that it is non-invasive, which is, has a huge, obviously, impact in the quality of life, the way that we treat these children. And of course, the immediate question comes, is this in contrast with the CED? No, it's not. And in fact, there are, we are working on identifying how you can even combine technologies in order to maximize the degree of the diffusion of the drugs. And of course, each one of them has the limitations, but both of them equally exciting.
Is this a sequential test where you the ultrasound followed by drug infusion, or is a drug infusion going on all the time?
At this stage, what we are experimenting with is using oral medications who we know that they have very poor penetrance in the CNS through the blood-brain barrier, to use the ultrasound to prove that we increase the concentrations. We're at this level now, which obviously is a lot of work, because immediately the immediate thought someone would have is, how about the risks? Because you're opening the blood-brain barrier with an ultrasound, what happens with the other substances that you don't want to have in there? So there's a lot of challenges.
Understandably. So I see that we are nearing the end of our hour together. And I always like to ask our panelists for a little take-home pearl of wisdom. I've forewarned them, so then they even if they get a little white in the face there, they've been forewarned. But we've talked about so many different areas and so many different amazing advances. Tell me a little bit about how we're going to make this a difference to a much broader non-research kind of area. Jovana, I'm afraid you're up first.
So, I mean, what I've heard kind of from all of us talking, and something that's really struck me is that one, we're really using new technologies, very highly interdisciplinary new technologies from different collaborating departments. You know, we talked about biomedical engineering, we talked about the systems biology department, all of these. And so really thinking about the many different ways we can leverage exciting work that's going on across many different fields into our care, I think is so exciting. And the other thing is just how connected everything is. You know, Stergios brought up how we're doing a project in DIPG, and what's so exciting is I can leverage my systems biology methods to try and identify new drug targets and try to identify, you know, predict therapies that might work for DIPG. And the hard thing is a lot of these we may not be able to get in the brain, but he's working on finding ways to get them into the brain. And we have other collaborators at Columbia and internationally who are working in the lab to then study these in different types of models of DIPG tumors. And so all of those collaborations, I think, are what's going to drive this forward and then eventually bring this into patient care and bring it into something that's going to make a meaningful impact on how we treat patients.
Great, good. Monica, what should we take home tonight?
You know, I think listening to everybody as well, I think what has struck me is how dynamic our fields are and how things are evolving and changing so quickly. Things that we wouldn't even consider 10 years ago are now becoming mainstream and being offered to patients. I think that for my particular discipline, I feel like for sickle cell, there really is a lot of hope for families and patients. And I think that what was once considered really a death sentence, 30, 40 years ago. I think the sky's the limit for these patients. I think, again, there are multidisciplinary collaborations with hematology, genetics, and I think that, the sky's the limit for a lot of our families and patients.
Agreed, agreed. Stergios, you get the final word, please.
Yes, also share the positive outlook of in all fields, including the brain tumors. These past few years, there was a major step that was achieved in understanding the biology of the tumors. And unfortunately, this has not translated yet to improvement in therapeutics. But as we described earlier, it seems like it's time now to utilize technology not only at the drug level, on the choice of drug, but also in the way that we deliver medication specifically in brain tumors. This fascinating technology that Jovana and Darrell are using, we are going to be utilizing to choose the drugs, but also to deliver them in an appropriate way for the brain tumors. So we are in a very, very important part of history in terms of brain tumor therapy, and I'm very excited to be part of it here at Columbia.
Terrific. And if I may add my 2 cents to this, I've been a medical journalist for 40 years, and I was talking with actually about a year or so ago with Dr. Francis Collins, the head of the NIH, and I said to him, Dr. Collins, in 40 years, things had moved very slowly. More has happened in medical research, particularly pediatric research that we've been talking about today. More has happened in the last 5 years than in the previous 35. And he said, absolutely true, and it's skyrocketing. It's an exciting time to be working in this field. And I guess my take-home message is cavalry's coming. Hang on, we're going to get there. And with that, let me turn it back to Darrell for some closing remarks, please.
So, thank you. I think that was spectacular. I think, what this shows is there is hope. There's a lot of innovation that's going on right now, and that we're starting to enroll patients on the various different trials, whether it's the Crispr trial, whether it's the CED trial, the patients who get their tumor sequenced through our PIPseq program. So I think there's a lot of excitement. There's a lot of hope for these patients. And I think that's that we're all looking forward to do, is to be able to really deliver on the promise of these different technologies. So I think with that, I think there is one question that do we have a time for a question, I guess? I know there's a question, Monica, that can you please repeat the requirements in order for a patient to be treated with the CRISPR-Cas9?
Sure. So right now they are enrolling patients who are 12 and above. On the sickle cell trial, they're only looking at patients with SS disease and S beta 0 thalassemia. On the thalassemia trial, they are looking at patients with beta 00. For the sickle cell patients, they need to have had, I believe, 3 crises a year for the 2 years prior to enrollment, or 2 acute tests. At this point, they are not looking at patients with CNS complications, but the hope is they will ultimately extend that.
Terrific. Thank you all. Thank you to our panelists. Thank you, Darrell, as well, of course. And we hope that you've taken some lessons home from this, and that you have renewed hope for yourself and for your patients. And we will see you again. We will be circulating a document with most of the material, or all of the material here that we've talked about this evening. So you didn't have to be taking notes. We will send that along shortly, within the next week or 10 days or so. Good night, and be well, stay safe, wear a mask.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Good night.
Good night.